Occipitocervical instrumentation with plate and lateral mass screws. There are a variety of methods of affixing the skull to the upper cervical spine. This is but one of many. In this case, the patient sustained a Jefferson fracture and was initially treated in a halo vest orthosis. After several months, the fragments of C1 continued to separate, and as you can see on the coronal images, there is an overhang and offset at the atlantoaxial junction. Functionally, the transverse ligament has been injured as well. One can see the injury to the ring of C1 in these images. For the occipitocervical fusion, positioning is everything. A significant amount of time is spent positioning the patient in a completely anatomically neutral position, making sure that there is no chin on chest or lateral rotation of the cervical spine. Once the exposure is made, in this case, C1 lateral mass screws cannot be placed as there's been an injury to C1. So we put C2 screws in, long pars intra-articularis screws, utilizing image guidance. The occipital plate is fixed exactly in the midline. Again, image guidance can be used for screw depth. It would be nice to get bicortical purchase of these screws. If one does breach and we get either CSF or a little bleeding, the screw is placed and this stops. It should be noted that the plate should be placed loosely at first. If one tightens down the cortical screws into the suboccipital bone too tightly, the lateral grommets cannot move and you cannot affix the plate. At this point, we're making an incision overlying a thoracic rib just underneath the clavicle on the patient's left side. Subparietal dissection with multiple dissectors takes all the soft tissue away from the rib. The rib is actually the perfect substrate for the occipitocervical fusion. Here we are harvesting the rib. Once the rib is removed, hemostasis is attained and that wound is closed in standard fashion. The rib, in its curvature, fits perfectly into the occipitocervical junction. In this case, we bisected the rib and wired it to the rods and also to the ring of C1. The goal in this surgery is to have drilled a trough into the skull and to decorticate the bone so that there is a structural graft between the occiput C1 and C2. It is not good enough to lie bone down on both sides, whether it be allograft chips or whatnot. What we need to have is a structural graft. Ultimately, we see each piece of rib is slotted into the skull, compressed against C1 and C2. Additional decortication can then be undertaken, and additional demineralized bone matrix can be packed along the bone. But at the end of the day, solid arthrodesis in this region is dependent on structural graft. Here we're placing some demineralized bone matrix putty and ultimately some vancomycin powder. Here we have a beautiful construct with suboccipital plating and long pars intra-articularis screws with structural graft between the occiput down to C2.